Hello and welcome to today's Teach Me Tuesday. My name is Lisa. I'm an experienced NICU nurse and a NICU nurse educator here with another topic to break down with you, and that is part two of the late preterm infant, carrying on from what we discussed last week. And as we know, we define the late preterm infant as those babies born between 34 and 36 and 6/7 weeks. And while they may look similar to full term babies, they are neither full term nor preterm, and they fall into this weird gray zone. Whenever I'm precepting someone, I always say, I would take a 24-week admission over a 34, 35, 36-week admission any day. With a 24-weeker, we know exactly what we're going to do, attempt to do. We are going to do the golden hour. We're going to put in lines. We're likely going to have respiratory support in some capacity. I can easily anticipate what the next step is. With a late preterm infant, they may come to the NICU initially, they may not. They may come down initially for observation. Maybe they come down because they need some temperature control, but then that turns into sugar control, which turns into respiratory control, right? And so their cascade of events can sometimes be delayed, and it almost makes it harder to kind of know what to anticipate. You know what to look for, but you don't know, okay, I'm getting a 35-weeker. Every 35-weeker is going to come in on CPAP and need a PIV, and we're going to start D10. Because if the baby's less than 2 kilos, likely they're getting more than D10. Maybe they're getting D10 with amino acids. Maybe their IVs are terrible and you end up with a line, but you didn't know that right away. So sometimes these admissions drags on because they are vulnerable with both temperature, glucose, and thermal regulation. Then you throw in feeding on top of that. So a lot's going on. We talked about a lot of this last week. This week, we're going to review what we talked about, dive into lines and discharge teaching. So, as we know, these were the five big things in addition to sepsis risk that really kind of we see as the most common issues in the late preterm infant. That's thermal regulation, hypoglycemia, hyperbilirubinemia, respiratory distress, and feeding immaturity. We did a whole 13 slides on this last week. So, if you missed it, pause me and go watch that one. What kind of lines may we expect in these babies? Most likely, if the baby needs IV fluids or antibiotics, you would be starting a peripheral IV. We do not automatically jump to UVs in this patient population. Yes, they may be needed if there is sepsis, severe respiratory distress, poor access where we really cannot get or maintain access for these babies is absolutely something I could see us needing a UV in. Hopefully, your unit has a PIV algorithm where you talk about how many times a baby should be poked and the escalation to who it should be next before you would put in a line. We are going to talk about PIVs next week in Teach Me Tuesday. Spoiler alert. So just know that that's coming. Often, late preterm infants may need an NG or an OG to help with feeds, and then they may need glucose support in the form of D10 or TPN or D10 with amino acids, kind of depending. And of course, if their sugars aren't good, which we talked about in hypoglycemia in the past, we may end up needing something like D12 and a half, so escalating as needed. One thing I want to be sure we talk about here is that we have talked about total fluid calculations. We will review that again in the late summer part this year. However, what I really wanted to point out is that you may start on IV fluids because the baby's initially on CPAP, and then the baby kind of gets over their TTN and now is doing better, and we start feeds. The weaning of the IV fluids as we put the feeds in is going to feel rapid, especially compared to a preterm infant. So it is your job as the bedside nurse to be on top of your orders and know what your IV fluid should be running at, what your feed should be doing, and knowing, hey, we might have a few weans on my shift and being prepared for that. How is PIV placement different in these infants? What I always like to point out is that their skin is going to be a little tougher than the extreme premature infants, and they may be chunkier, and you may not be able to see the vessels as easily. This is when you may need to utilize a light to help you see, and to remember that the skin is going to be tough, so to hold it taut. They also tend to lose their IVs because we do a lot of handling. Hopefully, they're doing a lot of skin to skin. So, really teaching the families, hey, what you need to be watching for if you're going to get the infant in and out, either call me, or if you are comfortable, you've got to watch this like the hawk, because if it comes out, I am going to have to put it back in. It's also important, again, going back to those total fluids, to know when would I need to put it in and when would I not need to. There are some transitional care model units that have IVs, especially IVs that are only in for antibiotics on mother, baby, or labor and delivery type units. So it's important that we may need to even tell the parents more about that line. And then watch for your IV infiltration. It can sometimes be missed on these infants, and we'll dive more into that next week. These infants are also going to have feeding readiness and cue recognition that's going to be similar to a preterm infant who is now coming into feeding, right? We're watching for a waking up, for rooting, telling us that they're ready, waking up before their feeds are due, non-nutritive sucking. But they often get started pretty good, to be honest. Late preterm infants can usually get a pretty good suck going, but it's coordinating with that swallow and the breathe and keeping their suck strong and engaged long enough to get in the volume that they need to maintain their blood sugar in a healthy level. So we really need to watch that and for sustained awakeness because sometimes these infants also fall asleep easily while eating, which brings us to the idea that these infants need to be able to do breast and bottle feeding practice. I do think that this population, and I actually recently saw an article about this, the late preterm infant population has a lower percentage of going home on breast milk. And I think that's because we give parents this idea that we've got to get their sugar going, we've got to get them feeding to get out of here. And the parents don't want to be there, right? If you have a 35 weeker, you probably thought you're pretty in the clear. And here we are, and they just weren't prepared. So it's our job as the bedside nurse to encourage going to breast first and to have continued practice at breast. Watching for that weak or disorganized latch, making sure that they're opening their mouths wide enough, right? We really want to make sure they're getting the whole areola in so that they get this whole full latch in order to have an effective suck, swallow, breathe, and to be withdrawing the milk out. So that's something to really watch for. Watch this non-nutritive sucking, doing skin to skin, especially if we cannot feed for whatever reason, whether it's respiratory or anything else that's going on with the baby. And if we are doing bottle feeds, consider that ultra preemie or preemie nipple or slow flow to be able to, keep up with their suck, swallow, breathe. Now we're going to talk about discharge teaching. And first we're going to talk about thermoregulation. So these infants can be more prone to cold. One thing I always talk about when these infants go home is they should be in one more layer than you're wearing. So right now I'm wearing a long sleeve t-shirt. And so if I had a newborn, which I don't, sadly some days, I would have them in a onesie that's long sleeve and a sleeper, or a sleeper and a swaddle, right? There's my one more layer. I think that is such an easy, quick visual for the parents and what they can do to help. Using a hat, keeping the house at a pretty recommended temperature. I think 68 to 72 is great. I personally we keep our air conditioning at 73, so I'm already like, oh my gosh, would I need to adjust that if I had a baby here? Teaching them what signs to look for cold stress, and then this idea of avoiding overheating. Did you know that two of the highest risk factors for SIDS are overheating and smoking in the home? So we want to make sure that they're not overdressing the baby with this kind of panicked idea of what would happen if the baby got cold. If you're discharging a baby home in the winter, they should not have a coat on underneath the car seat straps. The strap of the car seat should be as close to the baby's skin as possible. So make sure that you're always teaching that. With feeding, we want to let them go home with a minimum. Like we either need them to be breastfeeding for 20 minutes followed by 10 mils of a bottle, or they need to be taking 1 ounce every 3 hours, whatever it might be that you've worked out with your team. Hopefully, if there's a situation where maybe it's breast and bottle, we have a majority of breastfeedings and a minority of the bottles. Often we will do that, and the bottles will have increased calories so that we can kind of compensate for these breastfeedings. Keeping a feeding log was super helpful to me. Maybe that's because I was a NICU nurse before I was a mom, and so I needed the log for my sanity. But then also waking them up for feeds. Talking about lactation clinics, so many hospitals have outpatient lactation support and breastfeeding support groups, or places where you can come in and do weight checks, pre and post weight checks. Highly recommend. We also need to make sure that they are getting the volume that they need. And so this is going to be a big part of, are they sleeping? Are they peeing? Are they waking up for feeds? And are they sleeping long enough stretches in between? If the mom's milk is delayed from whatever reason, whether that be a C-section, preeclampsia, magnesium, separation, all of the above, we need to make sure that the baby's getting that adequate intake and watching for those signs of hydration in the form of wet diapers. Teaching them about the follow up and the readmission risks. Every baby that goes home from the NICU in general goes to see their pediatrician within 24 to 48 hours. Should also be true if this late preterm infant never left the mom baby floor. They cannot go 7 days before they have an appointment. It needs to be within 24 to 48 hours. And often they're going to go more than just like that once. They're going to need a continuum of follow ups to make sure that they're gaining weight. So I tell the parents to be prepared to be at the pediatrician at least once a week, unless there's home health coming to do the weights, which is amazing. I had a friend that did home health or did home phototherapy for her child with hyperbilirubinemia. So there are other things that could be supporting this, and actually got the lab draws at home and everything. So depending on where their support is, will depend on how often they are being seen by the pediatrician. That way, they also have an idea. As a parent, for me, I kind of want to know the high risk scenario, the worst case scenario. I am going to be going to the pediatrician once a week. Okay, then when I don't, I feel like a little bit better. Like, okay, I've passed that milestone. So I like to set them up with an anticipation of what likely could be happening. And I think that relieves some of their stress. So, what do we need to confirm before we send this baby home? We need to know that they are doing something with their weight. I think it's interesting. Late preterm infants may leave when they're only a few days old, and we know that babies can lose weight for up to the first 7 days. And the weight should be slowing, right? But I think it's just really important to think about what's going on here. They may not be on full breast milk feeds, right? Because the mom's milk isn't all the way in. They may be just recovering from a respiratory status situation, such as CPAP or high flow. So we really have to kind of think of them through a different lens and think, we've talked about discharge criteria for a preterm infant before, right? With preterm infants, we talk about gaining weight, stable temperature in an open crib, taking all food by breast or bottle, and free of apnea and bradycardia. All of these things are true. It just might not be the longest length of time, and the weight may not be there yet. So we need their blood sugar to be stable for more than 24 hours without any IV or glucose gel. Stable temperature in an open crib for greater than 24 hours. No heat from a radiant warmer. No supplemental oxygen. Watching our bilirubin. Has it plateaued and is on its way down? Do we know what our follow-up plan is? A car seat trial is indicated. The metabolic screen, the CCHD. If the infant is still losing weight and it's still too high, they're probably not going to go home. So, really giving those parents the idea of if the infant loses more than 10% of their body weight, they're not going to be ready for discharge. And so, that's another marker that they could be looking at and forwards and towards. So, something to think about there. What does a car seat education look like? So, in many, I would say most, I'm going to go with most centers, infants born less than 37 weeks are still receiving a car seat trial. This is not true in most California hospitals. They no longer recommend car seat trials. It is not true in Canadian hospitals. But outside of that, if you're born less than 37 weeks, regardless of where you're admitted to, you are going to be getting a car seat trial. So, something to think about. The parents will need to bring in the car seat. We need to do education on it, including proper positioning, no aftermarket products, no extended car seat sleeping once home, right? Getting the baby out, and kind of what to watch for. For the trial, make sure you're documenting that they were in, what their trial duration was, if they had a low heart rate or a low saturation, and getting that all in there. I remember when my daughter was born, she was 39 and 1, but they came in and said, I was in my postpartum room, was a 1 unit, right? LDRP. I labored, delivered, recovered, and postpartum in the same room with the same group of nurses. Highly recommend it. And she came in and said, "Oh, we have a baby doing a car seat trial for 90 minutes. Do you want me to take her to the nursery?" Because they were just going to be in there. And so I got like 70 minutes of solid sleep after days of labor and a C-section. So it was very welcome. But that's because there was an infant on the postpartum floor who was born less than 37 weeks and needed this car seat trial. So something to think about, even if you are on postpartum or you're a postpartum nurse or a mom baby nurse, you could still be doing car seat trials on those late preterm infants. So that wraps up this week for and our two-part late preterm infant cycle. As you know, I already mentioned what we're going to talk about next week, so I hope you'll tune in for that. Remember that these are not just small term babies, that they require some nuance, but we must treat them as individuals, right? There may be someone whose dates aren't quite sure, or they're 34 and 6/7 and they weigh 2,500 grams. Could we give them an opportunity in mom baby, in labor and delivery? Maybe they are 36 and 6 and they come out looking horrible, and we know they're going to need to be admitted right away. So, kind of getting rid of this preconceived notion of what we know is going to happen and letting the baby tell us what they need, going with where we should get an IV in, thinking about IV placement, knowing the baby could be held more, doing more skin to skin, preparing the parents for what discharge is going to look like. It may be more sudden for the baby to be ready to go home on a late preterm infant than a preterm infant. So, something just to think about and kind of cueing them for what may come next. And then recognizing those feeding cues, keeping warm at home, growing at home, and when to call the pediatrician. Thank you for joining me for this Teach Me Tuesday, and I will see you next week for a whole new topic.